Welcome everyone to the Johnson County Community Candidate Healthcare Forum. This is I think a first in some ways, but hopefully not a last. And I want to welcome you for coming. My name is Rob Stone. I'm a doctor. I'm a Hoosier. In the mid to late 80s, I actually practiced in Johnson County for a while. I worked at the Immediate Care Center at the corner of County Line and Madison. Thank you. And then for about 28 years, I worked as an emergency room doctor in South Central Indiana, and now I do palliative medicine and hospice care in Monroe County. So I just want to say that I'm also the director of an advocacy organization called Hoosiers for a Common Sense Health Plan. And our goal is to extend healthcare coverage to as many Hoosiers as possible and eventually to cover everybody. Sometimes we call it universal Medicare. But I'm not here to advocate tonight. I'm here to listen. I'm here to learn from the women and men on this panel and from everyone in this audience. And so I just want to say a couple more words and then I'm going to get out of the way. National polling data from January on has shown that healthcare is either the most important or one of the most important issues that the electorate wants to hear candidates talk about. And so we had this idea, we wanted to have a healthcare forum, we wanted to have the candidates. Unfortunately, we're not able to get Trey Hollingsworth here. We've been working for months and months, but he's not here. We've got Liz Watson, we've got an amazing panel of local experts who will be introducing themselves and being introduced here in just a minute. We're not really having a debate, we're having a forum, and there will be plenty of time for question and answer. And so I will now introduce our wonderful, from WFYI, Jill Sheridan is going to be our moderator from here, and I'm going to try to stay out of the way.
Thank you, Rob. It's wonderful to be here tonight. My name is Jill Sheridan. I'm a reporter at WFYI in Indianapolis and also a reporter for Indiana Public Broadcasting, which is a statewide network of the public radio stations here in the state of Indiana. And I've been on the health beat for a few years now, and I really have found a passion for the topic. I think probably because it impacts every part of our lives, and there's certainly no shortage of stories to tell. The landscape, the healthcare landscape in Indiana, though, is difficult and complicated. I've learned as I'm covering these stories the past few years. It's the intersection of policy, the intersection of social factors that affect us here in Indiana, and also the personal stories. So it's probably no shock at all that everyone's here tonight and that healthcare is at the top of issues as we head into this general election. So welcome everyone, and I would like to introduce our panel now. Mary Beth Hensley is a doctor here in Johnson County, a family practitioner. We have Michael Kolenda here. He is a director of WindRose Health Network. Also down there on the panel is David Dunkle. He's also a doctor and vice president of medical affairs with Johnson Memorial Health. And then 9th District Congressional candidate Liz Watson here this evening. And again, Trey Hollingsworth was invited and also declined to leave any information to the topics that we've started. So we'd love to just go ahead and jump in and have all the panelists sort of introduce themselves and the topics that they would like to highlight tonight around the issues that we're talking about: Affordable Care Act, healthcare in Indiana, and all the many complicated issues that play into that. Dr. Kolenda, I'll have you go first.
Is this live or do I need to go up there?
You need to, yeah, that mic should be live
This
there.
is live, okay.
You're good.
Good evening, everybody. Thank you for this opportunity. I'm glad to see you're here. I'm glad to know that this is as important to you as it is to me, because this is a terrific issue in our society that at times seems to be so misunderstood, overblown, and then times nobody knows it. Nobody knows it. How many of you got some of those handouts I was very clearly trying to pass out? That data is from the United Health Foundation's report they do annually. If you've never been on, look at that report. It is phenomenal in its information. And I share that with you because when I look at that report, and by the way, as the CEO of a federally qualified health center, we have to turn in a report every 3 years to the federal government to keep our grant that talks about the need in our community or in our state. And knowing that we're 38th out of 50 states, and in many areas even worse than that, such as obesity, it's very disconcerting to me because this hurts people, and it hurts people severely. And so my hope is tonight that we can talk a little about this and, you know, try to go in a direction about what can we do to make this thing more successful, because we've been talking about this for a long time in this culture. So let me give you your first question. Who was the first president, and what year did he approach Congress about a national health plan?
Harry Truman.
So who?
Truman.
Nope.
Wilson.
Who?
Wilson.
No.
Nixon.
No.
Teddy Roosevelt.
Teddy Roosevelt, 1912. Let me say that again. Teddy Roosevelt, 1912. We as a culture have been discussing this for over 100 years. We can't get it right. Lots of other countries have. We can't get it right. So that's just a thought for you. With that in mind, I don't know if I have a lot of profound things to say to you. I don't even know if I have any new things to say to you. But I do have information. I do have opinions. My staff will tell you I'm never short for opinions. And I hope that in the course of this we can discuss this about what are we going to do for our entire culture, our entire society, not those with privilege, those with wealth, but everybody.
Thank you, Dr. Dr. Hensley, we'll just go down the line. I'd like to.
So welcome this evening. I'm again Mary Beth Hensley, and I practice actually in Shelby County now. I was in Franklin for 8.5 years and changed about 6.5 years ago, so I'm a physician with Major Health Partners. I was the medical director of the St. Thomas Clinic here in Johnson County from 2006 through 2013, and an active physician there from 2003 to 2013. And one of my areas of expertise is particularly in life before affordable health care happened and life before access happened, and the need for the St. Thomas Clinic in the first place, and the difference in my practice and life since healthcare reform. I was speaking earlier about the number of Medicaid disability applications I used to complete for people, because in order to get access to health care, even for something temporary, you had to be unable to work at all. And the difference with Healthy Indiana Plan or the Affordable Health Care Act is that you could get access to health care even if you weren't full-time. So people who had real illness or injuries or other things that kept them off work had to be completely off work, and we had to fill out this long process to get them access to intermittent insurance. And now we have a lot easier access to that, or people can switch and have part-time employment. So the difference that people don't often understand is it was really all or nothing before. There wasn't kind of a fix where you could get a little bit of help but still stay in the workforce. And now the ability to have access through the healthcare exchange or through the Healthy Indiana Plan allows people to stay in the workforce. Even if they can't get a full-time job with benefits, they could have part-time work, maybe 2 part-time jobs, and get their benefits through the exchange. My second area of interest is pre-existing disease. I have a daughter who has ulcerative colitis. She was diagnosed in 4th grade. And I think about the change in that, like life before pre-existing clauses. And I remember there was a big change maybe around the time we started practice, where it was 6 months, you weren't covered for 6 months on your pre-existing things, and then it rolled into being covered by your new insurance policy, and how that would delay people's care and keep them from making life changes or cause all kinds of disruption if they had lost a job or had to change. And the concept that she would ever have to go without care is fearful to me, and I can't imagine going backwards for people, particularly, there's some self-inflicted diseases, I suppose, people who smoke and choose to do that in this era, or maybe self-inflicted diseases. But for children like my daughter, and you'll hear about David's son as well, who have inflammatory bowel disease, I just can't imagine her being punished for something that she didn't have any choice about. Her Remicade treatments are about $12,000 a dose. She has had to have them every 5 weeks for the last 3 years. And so we have good insurance, and I have a decent income, and I still have been sent to collections on a debt that just rolled up too fast for us to keep up with it. So those are my particular passions, but I have a lot of experience in primary care and disease management and maneuvering healthcare systems, understanding health savings accounts and those things. So I'd like to be able to touch on those tonight.
Thank you. Dr. Dunkle, go ahead and give us your bio.
Well, good evening. I'm Dr. Dave Dunkle. I'm a family physician with offices in Franklin and Greenwood. I practiced medicine in Johnson County for the last 15 years and currently serve the role as Vice President of Medical Affairs for Johnson Memorial Health. I feel that I have kind of a unique perspective in regards to the state of medicine, as I've had the opportunity to experience medicine from several different vantage points. As a freshman student here at Franklin College, I was diagnosed with acute leukemia. This led to several months of chemotherapy treatments, blood tests, etc., where I was able to experience navigating the healthcare system from the standpoint of a patient. As a practicing physician for the last 15 years, I've been involved as a provider. I also have a son with Crohn's disease, as Dr. Hensley stated. So I've interacted with healthcare system from the standpoint as a parent. Finally, since becoming Vice President of Medical Affairs in Johnson Memorial Health, I've also become much more knowledgeable about the financial pressures that charity care and insurance programs that pay pennies on the dollar place on healthcare organizations. As a physician, I'm trained to prioritize and triage my patients' complaints. I'm more concerned with someone's chest pain than I am with the splinter in their finger, though to them the splinter might be more visible. I feel that to fix healthcare, we need to do a better job of truly prioritizing what's important. For example, I know lately the opioid crisis has gained a lot of media and political attention. According to the CDC, 72,000 people died from opioids in 2017. Do you know, however, that there's 480,000 deaths per year in the United States due to cigarette smoking? 41,000 of those due to secondhand smoke. Last year, nearly $170 billion was spent to treat the cancer, heart disease, strokes, lung disease, etc., directly a result of cigarette smoking. To me, this is a much larger problem in our country. However, this doesn't seem to be a priority if you turn on the news, read the paper. Also in medicine, approximately 20% of the population accounts for 80% of healthcare costs. In fact, 5% of the population accounts for 50% of total healthcare expenditures. These are the patients that are the chronically ill. This is the population that we really need to focus on. Coordinating the care of the most sick and vulnerable is the only way to move the needle in regards to lowering healthcare costs. However, we must also find a way to hold patients accountable. I think that's one thing that's been lost in some of our systems. A couple years ago, Medicare started not reimbursing hospitals for readmissions. One of those conditions is congestive heart failure. If a patient gets readmitted within 30 days with the same diagnosis, the hospital doesn't get paid. I can still remember watching a press conference and President Obama saying it will make hospitals more efficient, which it has. There's been a lot of things that have gone in, a lot of processes to try to improve patient care. But we're lucky here, Johnson Memorial Health actually is among the nation leaders in low readmission rate from congestive heart failure. So a couple years ago, we decided that, why can't we get this to zero? We don't want anyone to be readmitted to the hospital. So we went out and we closely looked at the people that had been readmitted. And almost every single person that was readmitted for a congestive heart failure exacerbation had refused home health care. A nurse coming to their house to make sure to reconcile their medications, to weigh them, to make sure they were doing well. They refused that. They were admitted to the hospital, and the hospital had to pay for their care. So I feel that as a society, we all must be in the fight together to improve the health care of our population, to improve these costs.
Thank you, Doctor. Liz, about why healthcare is such an important issue.
Hi, everyone. First of all, thank you so much to the hosts of this event for setting up this important forum tonight. What I have found uniformly across all 13 counties in the 9th District is that getting out and listening to people. We all have our own healthcare stories. We all have our own experiences with the healthcare system. Listening to folks like the people I'm up here on this panel with, this is how we learn. This is how the person who wants to represent you should learn what it means to be your representative in Congress and should be able to take your priorities forward to Congress. Of course, the problem here tonight is that there's only one of us here, right? I am up in November against Trey Hollingsworth, and he has declined to show. And I understand he was given the opportunity to submit written comments, and he declined that opportunity also. Well, I am here and I am listening, and I'm glad to be here with so many healthcare professionals, because I am not a healthcare professional. I'm a lawyer by training, a labor and employment attorney, a 5th generation Hoosier. I specifically want to thank If It Was Your Child, one of the hosts of this event tonight, and acknowledge the really important work that If It Was Your Child is doing in Franklin in terms of standing up for children and standing up for public health and standing up and holding public institutions like the federal government accountable. This is very hard work. It's hard to go up against powerful forces like this day in and day out, and sometimes when your voice isn't being heard, but it's work that's starting to pay off, and so I want to recognize you. Healthcare is the #1 issue that I hear about in the district in all 13 counties. People who cannot afford to fill their prescriptions, people who need treatment for substance abuse but can't pay for it. People who got coverage under the Affordable Care Act for the first time, but are scared to death that they are going to lose it if these repeal attempts to repeal the Affordable Care Act work out. People who are on the brink of bankruptcy, paying for the costs above and beyond what their insurance covers, and who have no other choice but to keep paying until they go bankrupt. People in the middle class who are just one more hospital bill away from poverty. Business owners who can't afford to cover their workforce, who want to provide insurance coverage for their employees but simply can't afford it because the insurance system we have is unaffordable for them. I met a small business owner just last night in Johnson County who told me this exact story. I want to tell you just very briefly about a mom I met knocking doors in Johnson County. She's a mom, a single mom, who was able to get the coverage she needed when she had a pre-existing condition, breast cancer. And because she got the coverage she needed, she was able to be there for her child, for her little girl. She got treatment and she got better, and that little girl has a mom. If we go back to the days when people with a pre-existing condition can't get coverage, little girls like her daughter will grow up without mothers. We are the richest nation on earth. We cannot leave people for dead and dying. But that's what the attempts to repeal the Affordable Care Act would do, and I won't stand for it, and I know you won't either. Thank you.
Thanks, Liz. Speaking of the Affordable Care Act, we know that more Hoosiers than ever now have health insurance. And the Affordable Care Act is still the law of the land. There have been efforts, yes, from lawmakers to try to change that, and our very own Attorney General, Curtis Hill, has joined a number of other states in a federal lawsuit to invalidate, saying that they cannot defend the ACA, including protections for people with pre-existing conditions, one of the most popular parts of the law that we know. If I could ask everyone to sort of comment on the Affordable Care Act and about Indiana being involved in this federal lawsuit with a number of other states, as it goes to see how this healthcare law is the future of it here. David, maybe I'll have you comment first.
I think it's hard-pressed to find a physician who didn't like the Affordable Care Act. I mean, again, because we're patient advocates. I'm sorry. I say it as I think you'd be hard-pressed to find a physician not in favor of the Affordable Care Act, because again, we're patient advocates, not turning away people for pre-existing conditions, letting children stay on their parents' insurance to age 26, not requiring insurance companies to cover screening tests like mammograms, the great story you told, screening colonoscopies, making sure people are getting those tests where we can detect those cancers early. That's a great thing. And I agree, we can't, until there's protections in place for these people, we can't have the Affordable Care Act repealed. Now, I understand this question of legality. I'm not a lawyer. There are some questions, obviously, when the tax mandate got repealed with the legality of the Affordable Care Act, and I understand that, and it's a sticky situation. But again, I don't see how, as Hoosiers, we can be for that when that would leave approximately 3 million people with pre-existing conditions facing the chance of not having insurance.
Mm-hmm. We know that is such a popular part of the law, and we hear a lot of support around that. Mary Beth, what are your thoughts on Indiana and this lawsuit? Different pieces
I think, again, so much of it is education for people who have any opposition to it. I think understanding group risk and that everybody has to be vested, they have to be vested lifelong. I think, like he noted, patients being able to stay on their parents' insurance till 26 allows a whole maturity gap for people who are without insurance and maybe suffering some kind of illness or injury that would put them behind financially. I already mentioned the ability to have insurance despite the ability to work full-time, because it previously was always full-time work, full-time benefits, part-time work, no benefits, and the ability to stay insured through the healthcare exchange, even if you're only able to work part-time, contributes to society. There are people who may not be able to work full-time jobs to get their benefits, but they could work part-time jobs and get their insurance through the healthcare exchange. So going backwards is just not acceptable. And the conversation for people who are opposed or don't understand it is a lot of it's about education. They don't understand our policy. They don't understand healthcare savings accounts and pre-tax dollars. They don't understand all the things they can use. I still have people, probably once a year, I'll have somebody say, I don't have insurance, and they're 75. And I'll say, well, you have Medicare. Well, that's not insurance. Like, it's fantastic insurance. And they still are on the assumption that Medicare doesn't cover things. Medicare is fantastic insurance. And so over and over and over, just education and education and education about what their benefits are, how they use them, how they can shop, how they can be wise consumers. You know, when they have skin in the game, they pick and choose what tests they have to have or when they have to have them. And it helps us make better decisions about what's the priority. And so much of that, and my passion too with my patients, about education, 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 and letting them know what their benefits are, hunting for the best service, the best cost, looking around it. And anybody who's not quite sure of how that dollar swings around, I think needs to sit down and see the consequences of not having it. Then you go back to bad debt and what's the payment hospitals have to get written off anyway at the end of the year because of that bad debt. There's all kinds of conversations. So it just can't go backwards.
Yeah, it's certainly confusing. I mean, you can't.
Oh yeah,
I understand why people are confused. I mean, the system is very difficult, and yes, of course, education must be a huge part of that. Michael, if I could have you comment, on the Affordable Care Act, we're using that in the state of Indiana.
As I told you, you're going to hear a lot of good things, so I'll try not to repeat myself. So let's do this a little differently. Show of hands. How many of you, if you lost your insurance today, would step up to the next one and say, I got a pre-existing condition? Just about everybody in the room. Now let's keep them up if you know somebody who that would fall into that. Okay, all right, it's going to hit a lot of people. With a wife who's 1 year recovered from breast cancer, I'm really concerned about this, okay? That's like, you gotta be kidding me, right? And so I think this is very ill-advised. Isn't that a nice way of saying dumb as hell, but ill-advised? Okay, it's a very ill-advised strategy. I'm not even sure that strategy is represented by a General Assembly, because our General Assembly, if you recall, supported HIP 2.0, had money even before we did HIP 2.0 set to pay for the expansion of Medicaid. So they were all about it, because a number of people in the General Assembly get it when it comes to what the citizens of our state need. The common man needs, okay? So one of the things that Dave talked about a second, let's touch on some of the issues that would go away. The pre-existing condition one I heard all the time when I was working at WindRose from 2003 to about 2008. That was hotly debated when this came to pass. So did the things around keeping kids on your young adults on your insurance. Had 2 kids who did that. Both of them college graduates, came out, started entry-level jobs. One didn't even have insurance. Another one had what I would call catastrophic insurance. These are things that are being missed, and I think this is a party-driven decision that I don't think Indiana supports, quite frankly.
And certainly, we have a number of people in the healthcare world from Indiana on a federal level. It's interesting to see that intersection. Liz, your thoughts on Indiana and the Affordable Care Act?
Sure. The Affordable Care Act is by no means perfect, but it extended coverage to hundreds of thousands of Hoosiers and millions of Americans, and taking away that coverage is simply unconscionable. Our state's decision to enter into the lawsuit, this was a partisan decision. And that is what motivated all these other states that did that as well. Legal scholars who've commented on this lawsuit have called it spurious, have said that the claims have no basis. It's just a partisan gut punch to the Affordable Care Act. So the things we're talking about, taking away the coverage that, and you probably know that it's the coverage under HIP 2.0 that pays for things like substance abuse treatment, right? Taking away the coverage for people with pre-existing conditions means a lot of people in this room would be unable to get health insurance. According to the Kaiser Family Foundation, about 30% of the public in Indiana has a pre-existing condition. What's a pre-existing condition? Acne, pregnancy, anxiety. So what does it mean to go back to the days when you couldn't get coverage if you had one of these conditions? Well, I think one of the very first stories I heard when I decided to run, I sat down with a woman who told me about her niece whose father had lost her job. The niece was 13 and she got diagnosed with cancer, and they didn't have health care coverage. And then the Affordable Care Act passed, and you know what? The day it passed, they got the coverage they needed. This niece, who they thought was never gonna be able to seek treatment, got treatment. She got to walk across the stage of her high school graduation because of the Affordable Care Act. She's 19 years old today. Her mom and dad got to see her grow up. And they might not have her forever, but they have her for now because of the Affordable Care Act. Who are we as a nation if we're going to leave people behind? Who are we if we are going to leave people to get sick and die when we, the richest nation on earth, can afford to make sure that every single person has coverage?
Thank you. And on to another topic, you sort of touched on it briefly there. Even if you have insurance, we know that the high cost of healthcare, the affordability of healthcare, is a major issue. And many families are battling that issue right now. And I know that it's on the minds of lots of people. If everyone could sort of discuss their thoughts about what could possibly be done to improve this situation. I know that the ACA originally that was a goal, but we see the rising cost of drugs and treatment, and it can be scary. Michael, I might have you comment first.
Okay, as you know, multifaceted problem, multifaceted solution. There is no one solution. End of discussion. That's why we've been talking about this for 106 years. Okay? But one of the things I want to say to you, what gets me really charged up is what you've been hearing here, is people are getting, middle class people now are getting disenfranchised from this. It costs too much. I know people who pay more healthcare premiums than they do their mortgage. That's not a sustainable model in this culture. And this really calls into question one simple thing. How do we choose to govern? How do you want to govern? This is about government. It's about us. It's about community. It's about state. How do we want to govern? There are other models out there. There are other states that have done different things. Why not us? There are other countries that have done some different things successfully, despite the propaganda. Why not us? Are we too proud to say, hey, Canada's got a better system? Japan's got a better system, maybe? Why don't we figure it out? So my thought for you is this country has a long history of pulling together to help the country grow. Let's start with public education, 1840. We realized we're entering the Industrial Revolution. It'd be nice to have people could read and write and add and subtract. And it worked. It worked for us. The second one was when we did the Intercontinental Railroad, which we built, by the way, in the middle of the Civil War, if you didn't realize that. And why? To connect the country so it was one country, and we could have business take place, to have commerce take place. Electrification of the U.S. in the 30s. Do you think we did that just to make a nice big lake in Tennessee? We did it because electricity was necessary for us to go forward in the 20th century and be successful. I don't know if you know this, 2009 Congress passed a law, every citizen has the right to the internet and you can access it through the post office, or through the, library. Everybody. We pay for that, by the way. But why? It's necessary. I would say to you, we need to look at healthcare this way. It is a man-made asset, not water, not land, man-made asset that is essential for successful living in the 21st century. And if you look at it that way, as opposed to, oh, who's going to pay for it? Maybe we can figure out how we can accomplish this. A man-made asset everybody needs.
Thank you. David, will I have you comment on affordability and the price of insurance?
Well, again, I think it was great when Mike says multifaceted problem. I mean, I'll be honest, I'm vice president. Again, Mike hit on the nail on the head. He's talking about a multifaceted problem. Like, I'll be honest. I mean, I work for a local hospital. I work for a hospital that has to turn a profit. I mean, how do you buy that new MRI machine? How do you invest in new technology if you can't make a dollar? And there was a day when healthcare organizations made 18, 20% margins. Now hospitals are happy at 2%, 3%. How do you reinvest in your infrastructure? How do you hire new physicians? So again, I'll be honest, Medicaid and Medicare hardly cover the cost of the care of the patient. They hardly do it. And we talk about costs, you look at, for years, a lot of Scandinavian nations have been lauded for their healthcare and their social programs. But you take a country like Sweden. Sweden has an income tax rate of about 60% on average, compared to the United States at 27%. I think when you really get down and you ask people, do you want to pay 60% in tax? They're not, all of a sudden they backtrack a little bit. And I think that's tough. I think that part of the problem with pricing of healthcare is, obviously the insurance companies. I think that it's ridiculous that Dr. Hensley and I, we can't tell you how much it costs to see us in the office. It's different for everybody. Because one, Anthem Insurance says, hey, we're the biggest, or United now, we're the biggest insurer in the world. Dr. Dunkle, Dr. Hensley, we're not going to pay you what you want, because then we won't let you see any Anthem or United healthcare patients. We're going to pay you 70% of that, just because that's the way we do it. Well, then we have to artificially inflate our price. They pay this, and who gets hurt? The patient without insurance. Because in that contract that I signed with Anthem Insurance, I promised not to charge anyone else less. I'm not supposed to charge anyone else that cash pay patient who says, hey, I've only got this amount. No, I'll still work out a deal with them. And that's what you need to do to take care of people. But again, there are costs associated with that. And I think we need transparency in pricing. You need to know how much a test costs. Mary Beth talked about shopping around. Healthcare's need to be good consumers. And like anything else, if you're going to buy a car, you're going to buy anything, you need to know the price. In our system right now, no one knows the price of anything. Again, our hospital prides itself as a low-cost provider. But how do you know that? How does the consumer know that? And I think that's a big problem.
Having people be more invested. Mary Beth, please.
I was laughing too, because we're also not allowed, he's not allowed to tell me what Anthem pays him, and I'm not allowed to tell him what Anthem pays me, because that's against the rules too. And in transparency of pricing, there's a lab, any lab now up in Greenwood, that you don't even have to have a doctor's order to go get a lab. And it just says how much they cost, and you can just pay cash for it. You can walk in there and order a la carte. In our meeting the other day, we were having a discussion about spirometry, a lung test, and whether we would have it done in the office by standard, or if some doctors wanted it to be done in the pulmonary clinic, in the pulmonary lab. And the question at hand was, what's the difference in the fee of doing it in the office in a quick spirometry versus doing it in the pulmonary lab? And at our meeting, where we're all insiders, like you're not going to leak it out to anybody, they wouldn't tell us the cost difference of both of them, because nobody really knew. And like, well, yes, it's more. Well, how much more? It definitely would get more expertise and respiratory therapy and a whole line of education. But if you're going to charge the patient $500 for that, when it costs $42 to do a spirometry in the office, and my MA can educate them fairly decent and decide if they need additional testing. So the transparency of services is hard, even within a system, and certainly crossing lines where he's a Johnson Memorial employee, I'm a Shelby, a Major Health Partners employee. You can't talk this way. Now, there are reports of averages here or there and what the market in your area is. But if a patient comes in and says, how much is it going to cost me for that test? I can't say it costs this much. It depends on your insurance, it depends on your deductible, it depends on your copay. There are services like PayNav that are available, but again, educating the patient and making it easy for them to get to PayNav, to get that true cost, is still difficult. And it's a constant game of just smoke and mirrors. My other point on costs is tort reform, and we cannot have everybody being afraid of being sued for everything they own or everything they have based on a medical decision that is in the best interest of the patient. And there's so much liability in research and development for pharmaceutical companies, and that also jacks our costs up quite a bit. So somewhere, not to knock any lawyers in the room, but making sure we have legal reform too. So, just kidding.
All right, Liz, throw it right to you.
All right. So we spend about twice as much as any other country on healthcare, and we're on track to spend $50 trillion over the next decade. Why do we spend so much more? And our outcomes are often worse. Well, I think it's because, in part, that's how the pharmaceutical lobby, the health insurance lobby want it. I don't think this is an economic crisis. I think it's a political crisis. I think you can draw a direct line between the problems with our campaign finance system and the problems with our healthcare system and our inability to solve those problems. So I can't ask my dad for millions to buy a seat in the United States Congress like Trey Hollingsworth did. You know, as long as we award seats in Congress to the highest bidder, we'll have representatives who represent the 1% and not us, who don't have to worry about not being able to pay for the high costs of their care. My opponent has actually taken tens of thousands of dollars from the pharmaceutical industry, from the health insurance lobby, and then he's voted exactly the way they told him to. He's voted to take away the ACA. He's voted to allow junk plans to exist that serve nobody but the health insurance industry. He's voted to take us back to the days when you couldn't get insurance with a pre-existing condition. That's what happens when we allow people's votes to be bought. That's why I don't take corporate PAC money at all, because I think it's so important that we take on the big pharmaceutical lobby, that we take on the health insurance lobby, and that we start doing the right thing for consumers of care. Now, I think the right thing for consumers of care is to make sure that we cover all of us. We have 48,000 people in the 9th district who are still uninsured. We know Medicare is a system that works. It holds down costs. We just heard the doctors say that. It's incredibly effective. It's incredibly effective for people over 65. It would be incredibly effective for the rest of us. It's a system that I would like to see available to each and every one of us.
Thank you. The last topic that we had that we would like to discuss is a large topic. I feel like I do reporting on this all the time, and that's the issue of Indiana's health rankings and our health measures as a state. We know that oftentimes we're ranked right there at the bottom in many of these measures: diabetes, obesity, smoking. I'd like for you to try to outline this humongous topic, how you would like to see change, and what areas you would like to see healthcare for Hoosiers change in these measures in the short term or the long term, or however you'd like to touch on that. Mary Beth, I'll have you go first.
So some of the studies recently have shown access to walking trails, access to exercise facilities are one of the biggest and most effective change mechanisms to change the healthcare in a community. And I think particularly here in Franklin and Johnson County that you're seeing that happen around the community and people getting out and being active. The thing I see in the physician world is so much of the shaming of obesity. It has just happened in the last probably 5 years where they diagnosed or considered obesity a medical problem. We don't get paid just to manage obesity as a diagnosis, the coding system's called ICD-10. If my primary diagnosis is obesity, it's not a covered service for the patient, regardless of how important it is and how much it deals with their hypertension, their diabetes, all of their consequences of life. And so having change and finally acknowledging that as a medical condition, but moving forward to say, yes, we have access to programs and services and nutrition information and counseling and activities in the public forum is just so very important. I mean, people, surprisingly, they still don't know. We can talk about it 100 times a day. I said to a lady today, I said, have we talked about food diary before? And she said, yes. And I said, you know, you still get to heaven regardless if you're heavy or you're not heavy, or if medical problems or not. You might get there faster, but if you want to make change, I'll help you and I'll be there for you. And I'm not going to judge you if you don't want to make change. The part of that, though, is then the financial consequences. If they don't make change, that's the patient that's going to be hospitalized more and cost the system more. So I think so much public effort to getting access to exercise facilities and access to public education, parks, recreation, making those affordable for patients in all areas, and then also having a medical staff and a medical community that'll be part of that and be part of helping their patients in that journey if they're coming for support.
David, would you like to comment?
Well, I start out in my opening statement talking about, again, I think we're forgetting about the importance of the costs associated with tobacco abuse. Again, I'm going to harp on tobacco abuse again. I just feel, again, it's a great disservice in our state and our country that we're forgetting about the economic impact. In fact, I was looking today, $2.93 billion, the annual health care costs in Indiana directly related to smoking. Medicaid costs caused by smoking in Indiana, $589.8 million. Smoking caused productivity losses in Indiana, $3.17 billion. In 2016, $9.5 billion was spent by the tobacco industry on advertising. In the fiscal year so far, 2018, states will collect a record $27.5 billion from the tobacco taxes and legal settlements, but will spend only $721.6 million, less than 3% of that, on prevention and cessation programs. That is a huge, huge issue. We have got to fix that. We've got to fix it now.
Liz, would you like to comment on Hoosiers' poor health measures?
Sure.
How we can make that a focus?
So we've talked about certainly the smoking problem, the opioid abuse problem. One problem that we haven't touched on is we have a maternal mortality rate that's twice the national average, the 8th worst infant mortality rate in the country. A thing that I think a lot of us know is that we have a shortage of mental health treatment professionals across this district, and that is a very serious problem because we have a lot of families in real need. Actually, the last time the federal government looked at this, I think 12 out of our 13 counties were classified as a mental health shortage area. Some of the things that I think we ought to do, I think we ought to cover the 48,000 who are still uninsured. I think we ought to be very clear that we will not repeal the coverage that we have. Trey Hollingsworth, when he voted for repeal without meeting with Hoosiers first, said, well, of course there has to be a bridge, but there isn't a bridge. It's a bridge to nowhere, and there has been no plan. I support real investment and real funding to solve the opioid crisis. There's a bill that Elijah Cummings has introduced called the CARES Act, which is sort of like the Ryan White bill that was introduced to deal with HIV and AIDS and to really address that problem in a very serious and comprehensive way. The CARES Act would do that. We need to make real federal investment, not these drop in the bucket things that we have been doing so far. I want to talk for a second about our schools, because we haven't really touched on that. I have 2 kids who are 8 and 12 who go to my elementary school in Bloomington, where I went growing up. I go to schools across the district, and I hear our schools are often where these kids, their needs are being met when their families are suffering trauma, poverty, opioid addiction. The schools are meeting the needs, but they're doing so without the resources that they need. We ought to have a counselor in every school. We ought to be having a nurse in every school. We ought to have mental health resources for students in every single school, and we're not meeting that need at all. And that's a question of priorities and values. It's a question of where the money goes. And we can solve that problem. We can serve the needs of our kids in school. And the last thing I'll say is, let's not forget the importance of protecting our environment in all of this. Dealing with the environmental toxins that we have in Indiana. We do have a lot of old industrial sites here in our state. We need agencies like the EPA not to be gutted and defunded and to do their job of enforcing our environmental protections. And we need to not roll back the protections that are designed to ensure that we have clean air to breathe and clean water to drink. This is critical to our health.
Michael?
I'm not going to get as specific because I'm not sure with such a broad case issue we have, but I'd like to say some of the following. Ralph Waldo Emerson was a philosopher, one of the premier philosophers in our culture in the 1800s, and he was quoted as saying, the first wealth is health. Now, that's as true then as it is today, and I don't know if Americans embrace that, because I think they look outside themselves for health and finding health. So, just to give you a little example of this, please take this paper for a minute and go to the column that says best state, which according to the United Health Foundation had the leading number. And if you notice there, when you take a look at diabetes and you go to the right, what state do you see? Colorado. Best state for lowest rate of diabetes. Go further down to diabetes. Go to the right, what do you see? Colorado. Now, here's a little number that's not on there. State that has the highest amount of people actively exercising 5 times a week or more, best state. Want to make a guess on this one? Colorado. Why? That's the question. Why is that culture, why is that community, a set of communities, why? And why can't we do it? Well, I think the answers are, first of all, each of us has to embrace, doctors can only do so much. They'll tell you that right out of the box if you're not going to do certain things. And some of the things that affect us are 6 chronic illnesses, of which are lifestyle driven. It's what we eat, when we exercise, what we do with our view of life, like thinking positively, things like that all come into play. We are in control of this. We can do this. But that culture in Colorado, for some reason, it's done. Okay, and I can go into lots of reasons, but so I guess my thought is, one is, this is acceptance of it's my health, and I'm going to take care of me. That's number one. In this, my message is, everybody ox gets gored in this one. Okay, maybe it is 50% taxation in Sweden. Would you like to take a look at their lifespan? A hell of a lot longer than ours. Is that of interest? How much is that worth to you? That's the question. How much is it worth to you? You know, the Canadians, if you got this thing on the back, you notice Canadians, 5 years longer. Oh, by the way, you talk to Canadians about their health plan, they'll tell you, we like it, and we know we pay for it. So I guess my thought is, we got to have it individually, we got to have it at a governmental level and community level, and then I think we have to talk about how do we always have to measure this in the business model? Once upon a time, healthcare was created by religious organizations. That's the basis of our country. Most hospitals came out of some kind of, now they're big business. $2.2 trillion. Now they're big business. As is insurance, as is pharmaceuticals. We don't have to have that unless you want to do something. Of course, you know, I know I now sound like a socialist to many of you. That's fine, you know. I'm talking to you about ways things were done in our society for decades. And that the group got together and figured it out and made some sacrifices.
Thank you. We would love to open it up to questions at this point. I will ask that anyone with a question, I'll try to hear you speak loudly and I can repeat the question. And also maybe if you let me know if you would like that question directed to a certain panelist, or if you would just like it open, that's fine. Yes, sir, go ahead.
Yes, I'd like to direct a question to Mr. Watson.
Go ahead.
You finally got to the issue of Medicare for all. To use that exact word. That's the hot topic that basically we're all talking about. And Bernie Sanders has brought this up, as well as many other ideas. But what we never get is the cost. Let's get right to, have you analyzed in any way what Medicare for all would cost? And I know it's an insurmountable obstacle to get through to put the insurance companies out of business overnight. It could be a gradual transition where we gradually lower the age of eligibility and gradually increase the Medicare deductions.
Thank you. So the question is for Liz about Medicare for all and the cost of that.
Right, so I am a supporter of Medicare for all, along with 70% of the American public. That's 52% of Republicans and upwards of 80% of Democrats. Polling just came out. The other very important data point that recently came from a Mercatus study that was funded by the Koch brothers. And stuffed into a footnote, I think in the back of the study, was actually that the overall costs of going to a Medicare for all system would actually be cheaper by $2 trillion over the course of a decade. I think they studied 2021, assuming implementation 2021 to 2031, than our healthcare costs now. That we would actually bring down healthcare costs. And how did they get to that conclusion? Because you have to think about the overall costs that we all pay for care, right? So we pay very significant costs in terms of what we pay administrative costs and overhead. Doctors' offices have to employ whole, staffs of people to negotiate with insurance companies to try to get coverage. The overhead costs associated with that are very, very expensive. We know that if we could negotiate prescription drug prices under Medicare, just as the VA does, we would dramatically reduce costs. One of the things that they don't talk about, I never hear people talk about this, is the savings associated with having healthy people, right? Because when you're healthy, you're able to be in the workforce. You don't need to rely on cash assistance programs as much. You don't need to move to Social Security, to a disability program, because you are healthy and you can work. So the cost of making sure that that people get that coverage that allows them to lead a healthy, happy life and participate in our workforce, and the economic productivity that we gain associated with that is something no one ever talks about, but I think that we should.
Thank you. Yes, sir.
How does that answer pair with Dr. Is it Dunkle, his opinion that Medicare does not cover the cost? So when people hear that, they're saying you're advocating something that's going to drive the professionals out of business because it's not covering the cost. So I need to balance, that answer with somebody that's coming out with that other statement.
David, does anyone hear a sort of understanding of Medicare?
Yeah, it's very tough, because the other thing, people, we talk about Canadian healthcare system, the Swedish healthcare system. The other thing is, Americans, we love our care. We love to do what we want to do. You have to understand too, some of these Medicare for all socialized type programs, don't think it's not going to be dictated what you can and cannot do. There's a reason why so many people come across the border to get their gallbladders out. I mean, that happens. There's a reason why my partner left the Canadian medical system to come practice in the United States, because he was working 16 hours a day going bankrupt.
So it's 30 years ago.
To think that the system would be the same as it is now, just cost less, I think is idealistic. Also, I think coverage does not equal health. Just because people have coverage does not mean we're going to make the population healthier. Again, I think going back to what Dr. Hensley said, you need community initiatives. We need more trails. We need to make sure our children aren't obese. We need to watch the nutrition in the schools. We need to get the Coke machines out of the schools. We need healthy snacks. We need kids to understand you have to exercise every day. I have patients who they can take PE class online now. Are you kidding me? Online. I mean, we have got to get our children exercising. Again, so much what we look at is fixing the end. The people, as I talked about, 80% of our healthcare dollars being spent on 20% of the population. But we need to focus on prevention as well, and we need to start early.
Dr. Hensley, one comment.
So, and I'm not even saying that Dr. Dunkle and I necessarily differ, but Medicare is not a poorly paying insurance. It doesn't pay top dollar. It doesn't pay bottom dollar either. So Medicaid may be a different story. So the Medicaid reimbursements are a lot lower than Medicare, but Medicare insurance in general is a reasonable payer. They pay on time. You submit a bill and you get reimbursed. Your reimbursement is electronic versus a lot of the private insurance companies will hold that payment for up to 3 denials before they'll submit it. So there is a balance in that it's not, because you could get really fearful, and the Canadian physician he's referencing practiced in Canada 30 years ago. He's been here a long time, so things could be different now than they are then. But having one payer and one mandate and not freedom of choice isn't necessarily what I think either one of us would advocate, but we also see that everyone needs access. And so the offset of having, a Medicare population that pays kind of a reasonable price, maybe an Anthem or United that pays like 125% of Medicare, so they'll pay us great dollars. And then you have a Medicaid that pays like $27 for an anesthesiologist to give a lady an epidural for her labor. I mean, that's not adequate coverage for that anesthesiologist to come in and manage that. They have to be there the whole time the lady has the epidural, so 8 hours for $27, I think it pays for Medicaid epidural. So there's glitches in the system that would have to be, they'd have to be adjusted. But I have yet to meet a starving physician. I mean, I certainly have had financial issues in my career and balance and budget and all the things, and the days of making $500,000 as a primary care doctor are over. And frankly, they probably should be. Our neurosurgeons, our cardiothoracic surgeons that are going, 7 years longer than we did to school and have to be on their feet for 18 hours for an OR, they need to make that dollar. I don't need to make $500,000 a year. Would I love to? Sure. But it is that reasonable. So a lot of people, I remember a lot of urologists griping about their pay, and I know 2 of them who just retired at age 55, and I've never seen any of them in a food bank. They're all fine. So it is a yin and a yang that, we make $200,000 in primary care. Woe is me, my peer that retired, opened my practice. I know he had years in the 70s where he made $400,000 and didn't make $150,000 in the late 90s. But that, you have to balance it. So it is important that the prices be adjusted, because nobody is going to get an epidural from an anesthesiologist on Medicaid. Well, they have to come do it, but I think the reimbursement's like $27 for them to do that. That's unacceptable. Right. There's way too much liability with that time spent. But Medicare in general is kind of in the middle of the ballpark, and finding a way for that to be consistent and reimbursements to be consistent is really important. So
that system works. Why can't others? But questions? Yes, ma'am.
Mine's more of a statement, and excuse the way I look, but I can't as part of the medical system today to get better. You were talking about the cost. You have to look at what he's talking about in Sweden. Those people have paid high taxes, but they have their health care, and so that doesn't come out of their pocket in addition. It's already paid for, and they have not paid anything extra. It's like my mother's mother. They used to have a country doctor in Dryden, and every family paid in X number of dollars to have the doctor there, and then he treated the whole family. That was the kind of system. But we are so busy being selfish and greedy, and I don't want to spend my money on somebody else. Let me say this, and this is a preacher. Christ told us to do 3 things. Take care of the poor, take care of the widows, and to take care of the sick. And if you're not doing those things, and another thing I would recommend to everybody, please listen to Rick Steve's discussion on travel and political life. Because what he says is, when you go to other countries and you see the way the people live there, and you see the difference in the economics of people. The downfall of our country is that we've got this great amount of riches and this great amount of poor, and there's nothing in between. And if we don't correct that, when people like Mitch Daniels get in and they cut property taxes, then what do we hurt in schools? I was a school teacher. Excuse me, you all ought to pay me more than anybody else in the world.
And a shout out to Rick Steves. Dr. Kolenda, if you'd like to comment, we often hear,
Thank you, very good feedback. And one of the things that I think, again, I go back to this notion, when we start talking about this, all we want to talk about is money. I'd like to talk about value, because Americans in the room will pay for stuff of value. Anybody gone to a Colts game lately? Did you get your money's worth? Oh, by the way, you got charged a lot. So when we talk about value of this, and when I talk about in Canada, they have 5 years longer health span on an average. I don't know if that's valuable to you, I guess. If it's not, then continue the discussion about money. Tao Te Ching was written by a man called Lao Tzu 2,500 years ago. One of the lines of the Tao Te Ching goes like this, and this is not word salad. A man who knows when enough is enough will always have enough. We have lost a sense of value about health care. And part of it is because our focus is on what? Disease only. Health is not just the elimination of disease. Health is more than that. The data I gave you guys out there about suicidality, that frightens me for our culture. That the second leading cause of death for people ages 10 to 34 in this country is suicide. Let's talk about money now, shall we? Because that's not about that. Come on, that doesn't make any sense. They chose to leave life. Really? So that's where I want to say, when we talk about this sometimes, are we always going to measure it by the money? Is that what we're going to do? Because that's not quality of life for me. And yes, I will pay more. And yes, you can tax me more. Because I want quality of life for me and my community.
Thank you. Anyone else? Questions from the audience, sir?
Just a comment. I wanted to give Michael some kind of kudos because I'm part of your system. And I really like him. I'm over in Little Trafalgar and
Great.
Loved by Dr. Chipley. And you use some kudos because I can see them when I want to. They're very accessible to me, and you run a great organization.
Thank
so
you.
As far as, and we haven't always been that way, but
Yes. Yes.
Right.
And we got to keep working at it. I'll be very blunt about it. But thank you. That's very generous of
just to
you.
give some kind of kudos. So Liz, you already have, being a school psychologist for 40 years, you already have school psychologists in most of your schools. And that is part of the mental health inroad to helping starting, not when they get out here. Every problem you're talking about, smoking, obesity, starts back in school. Thank you. And
There isn't a psychologist in every building.
there is
And
Certainly not.
there isn't even a nurse in every building.
Sure.
You're stealing my thunder. Unfortunately, the legal system has gotten, and you're a lawyer, so I'm going to throw this at you. My reports when I started 40 years ago were about 3 pages, 4 pages long. Now when I left, it was 17 to 18 pages long to get a child help in the last study hall of the day. In other words, you would have to go through all these professionals to get a kid support in a study hall at the end of the day. Somebody needs to look at the legal things that we're required to do as a school psychologist and try to eliminate those and make them faster instead of more of our time with teachers, poor teachers having to document everything.
Let's do.
So many people. Any other teachers in here?
Yeah.
Am I telling you anything you don't know?
No.
Do you want to comment on that, Liz?
That there's so much documentation and so much legal stuff that we have to do. We can't really see the kids. And it could start at school. One thing, mental health stuff would start at school.
And that's support.
Well, I'm certainly sympathetic to the idea that we ought to streamline the paperwork that folks have to deal with in order to be able to get kids the services they need. You know, I think our schools are really doing so much more than I mean, teaching itself is a huge job, but really our schools are often in the position of having to wrap their arms around kids in our communities because we do have so many kids coming from families in poverty. I think about visiting Corden Elementary School, where I was told that kids were coming to school from a homeless shelter sometimes, that kids would have meth on their clothes and have some sort of reaction in the middle of the day to that having seeped into their skin. And the entire school was trying to wrap their arms around those children and deal with those problems, but they did not have sufficient resources to do it. I do think I want to mention one law that I think is very, very important, and which is important to the health of our children, which is the Individuals with Disabilities in Education Act, the IDEA. You may recall that at her Confirmation hearing, Betsy DeVos did not know about the IDEA. She didn't seem to know that it existed or what it was for. This is to make sure that children with disabilities in our schools can access the general curriculum and that they get supports, and school psychologists are often involved in that process. That's really, really important in meeting the needs of our students, that we fully fund the IDEA and that we make sure that we are able to allow every single child in our schools to succeed. It's been important for my family personally, and I want to make sure that it's there for every single child in Indiana.
Yes. Hi, my name is Jared Stancombe. I'm actually running for state representative, but I've actually taught in the school, and on the bus ride to my school, we stopped at the local homeless shelter and picked up some of my students. And also I had a suicide attempt at my school with one of my students too. So I've been in the trenches in the public school system. But my question for everyone is, we talk about healthcare, but what is the role of, say, local health departments? And I mean, I'm from Lawrence County, so 2 years ago we had a hepatitis C outbreak. Now we have nearly 50 people with hepatitis A. Austin, Indiana has over 230 people with HIV, and I'm just interested to learn how we can empower health departments, given that Indiana ranks 49th in public health spending.
Right. Michael, you might, yeah, take that.
I was going to say, if you want to guess where we sit when it comes to how much money we spend, our legislators let us spend on public health, $38 a Hoosier. That's number 49. Hey, we're number 49! Woohoo! And yeah, that causes some real problems for our hard-working health departments because they really don't have any resources. Now, by contrast, go back on this thing, take a look at Hawaii. Of course, you know, they got great weather unless there's a tornado or a hurricane or a volcano. But guess who spends the most money in the nation per capita on health care? Public health, Hawaii. And there's a correlation between that and some of their public health issues. I mean, you got to invest in it.
Yes, sir.
Yes, I am concerned about rural community health care. It seems that health care in our rural communities across the state is in full-on retreat. We're watching, we talk about health care programs, and yet a majority of our rural communities have no OBGYNs and no pediatricians. So how do you institute a program into these communities where even basic health care for our women and our children don't even exist?
David, maybe you'd like to tackle that, or Mary Beth? I mean, we do know that provider shortages are a reality in the state.
I think it's incredibly difficult. You know, I was doing research, came across that actually one of the biggest, we talk about hospital closures a lot due to reimbursement. 80 rural hospitals have closed. I was just reading Becker's Healthcare this morning. You know, it's tough because, again, you get into it, it's tough for a physician to go into a small community and to make a living. It's hard for a hospital to exist. I really think the answer probably relies in a combination of bigger organizations helping out the smaller towns. I think sending out physicians. I think utilizing technology. We have things such as telemedicine. There's programs, and they do this more in the inner city now, where, you know, they'll set up a trailer with a nurse practitioner who has an otoscope, all the equipment, and the physician is sitting in his office, literally virtually seeing those patients. I think that is one way to start. But again, I think that takes funding, that takes help from the government. But you're exactly right. That is one of the probably the biggest shortfalls in the medical system right now is those rural communities. Because a lot of times too, they're worried about transportation. I mean, I used to work the ER in Rushville, and it was amazing to me. I would have someone come in the ER with chest pain who had open heart surgery at St. Vincent and had never gone back for their follow-up visit because they couldn't get a ride. So.
I'd like to comment on that as well. So the utilization of advanced practice clinicians is just a huge point of access that's underutilized. So I personally, for a moment in time, up to a couple of years ago, had 6 advanced practice clinicians. There was a time in Shelbyville and a shift in another partner that was with me, and all of a sudden he left and I had 8,000 patients to take care of. He had 3 advanced practice clinicians. I think I had 2 at the time. They were all still there. I was there, and the willingness of all of us to be a team to take care of this patient population was dependent on my willingness to participate in that. It's the best team of people I've ever worked with, hands down, the best partners I've ever worked with. But the conversation about advanced practice clinicians is different. I mean, Dave and I probably have different opinions on that. I know I'm part of a physician moms group that's 70,000 women physician moms wide, and the difference on, they're taking over our jobs and they have no right to do that. Well, probably 85 to 90% of medical problems can be taken care of by an advanced practice clinician, and certainly having physicians who team with that, it allows accessibility, because he and I can't work 27 hours a day. You can only do so much, and you have to be, taking the time to dedicate to your family was a big change in my life, to say, you know what, I can't be everyone's everything all the time. Do I care about every single patient? Absolutely. But if there's a primary care shortage in your area, you can take on, have every provider take on 1 or 2 advanced practice clinicians and make your availability there. And that's one of the ways to supply people with, and the cost per provider is less.
It compounds because of typically low income per capita across the counties.
Exactly.
Now it's easier to buy a box of macaroni and cheese. It's cheaper than it is to buy a head of lettuce or a bag of tomatoes. And so we see this problem now is not only a healthcare desert, but a nutritional desert as well. And our problems are compounded. I'm not quite sure that Medicare for All solves that.
I have one more comment on the food desert.
Certainly.
And I love my hospital that I'm at, but I will say, I was in a meeting this year when the food desert conversation came up for Shelby County, and one of our physicians, who's very intelligent, said, well, there's Amazon grocery delivery. I mean, there shouldn't be a food desert anywhere. And I will say that everyone else sitting in the room kind of looked and didn't say anything repulsive, but I thought, are you kidding me? You're sitting here and people think that way. Like, why would they have a problem? There's Amazon grocery delivery. And so we have to we got to call each other out on that a little bit. So I think somebody said that food stamps weren't taken by Amazon yet, but I think there's areas of people think, well, why would they not have access to food, or why would they not have that? Well, it happens all the time.
Right, sure. There's a lot of mindset on that issue.
So I want to say that actually part of the federally qualified health center model is very focused on rural health care. And part of the way we're able to do that is because the government pays us a wraparound fee for Medicaid so that we can afford to go in there. 80% of the people we serve at WindRose Health Net were on Medicaid or Medicare or self-pay, okay? Very few of them are on commercial pay, and we couldn't do without it. We put it bluntly. So this is actually your tax dollars in action, my tax dollars in action, that help try to address it. But what you're saying is true. Indiana Primary Healthcare Association has been working to try. They just got look-alike status for some clinics in Greene County. There's some down in Orange County they got this for, and there's a real push to try to see if we can find ways, because rural healthcare centers get paid more than the average doctor. State-funded community health centers get paid more than the average doctor. Why? Because they're very much what you say. You can't support the enterprise without it because of the low volumes and the cost of delivered care. Okay, so that there is some things out there, but Indiana has been behind the curve on all this. Washington State has twice as many, about the same population, twice as many F2HC sites as we have here. Some of that is about politics.
Yeah, health centers certainly an important piece of that puzzle. Yes, ma'am.
I don't know if anybody saw this on the news, but they had a New York medical school that recently announced that they were going to give free tuition from that day on to all medical students, graduating medical students.
NYU.
And yes.
It's NYU.
And that is a great thing, because you come out of there with $100,000 debt, and where are you going to want to work? Not
Try 250. The average is 250.
I just had a medical student last month, and he told me between undergrad and medical school, his debt was over $300,000.
I think they were just talking about grant.
And I actually, back to even what you were talking about, I had an interesting conversation with the dean of the Marion Medical School, and they're talking again about trying to recruit more people for primary care. Because to be honest, the first class went out into the world recently into residency, and they didn't have as many people going to primary care as they originally had thought, because again, it's tough. I mean, my specialty, Mary Beth's specialty, lowest paying specialty in medicine. There's a great need for family practitioners. They estimate the next 10 years are going to be 100,000 of us short.
Right.
So one of the things they were talking about is trying to tie more people into tuition reimbursement for agreements going back to these communities. And I think that is one thing as a state we really do need to kind of push for. We need to get people into those rural communities to serve them.
The state is some of those.
So just to give you a contrast, Germany, by which way, has universal health care. If you go through family medicine, that's how much it costs you. Then you got to go out and practice for 5 years. Okay, that much. Canada has a thing, and so does this state. There's something called the National Health Service Corps. We have clinicians that go through there. There is some tax-free reimbursement. In Canada, you complete there, you go work on the Yukon. Anybody like that idea? We work in the Yukon for 3 years, your medical debt's wiped out. Okay, so there are ways to skin this cat, but again, it's about who's making what sacrifice, and a group decision about this is important enough, we'll pay for it.
And I think actually at the federal level, this is something that we can support, loan repayment for and assistance, tuition assistance for people who practice in areas where there's a shortage, whether it's a practice area or a particular geographic area. I think that's really important. One of the things that was brought up on this in response to the question about how we're going to support health in our rural areas and access was telehealth. And I think telehealth is very important to pursue, but we also need to simultaneously pursue rural broadband access, which is a huge problem across southern Indiana.
Right.
And so supporting federal investment in providing access to broadband for folks in our rural communities is something that we need to do from a health justice standpoint as well as an economic development one.
Infrastructure.
So any of you had clinical care through telehealth? Show of hands.
Right, not a great awareness.
Okay, so I got, this was first introduced to us about 6 years ago, I said, you're kidding me, right? The kids love it, absolutely flat, love it. Even if it's behavioral health through telehealth,
Sure.
They love it. And other folks adapt to it.
Yeah. So,
Yes, there are 8 other countries besides Canada and the United Kingdom that have single-payer systems that are not socialized medicine, and they have freedom of choice, and they deliver the even better health care than what we do for 55% of the cost, and sometimes even less. The 2 myths that are popular among legislators and a lot of the public that it would be helpful if the health services community would combat them, and that is that Medicare-type programs are socialized medicine, which they are not, and that there is a free market in healthcare.
those 2 myths. Free market. Socialized playground. Anyone like to comment?
Well, I'm glad you brought that up because again, this was all the stuff was debunked and the Congress, both sides of the Congress said, we can't do that. Oh, God help us if we would copy Japan or somebody like that. We can't do that. Although they're kicking our butts in the automobile industry until we start copying them. But, you know, you're absolutely correct. And that I get very angry about that because it's the propaganda that you all hear and then you decide to vote for somebody because he espouses that propaganda. When it's like, get the data, will you? And that's what I get frustrated with.
Yeah, I just wanted to, on the cost things, because that seems to be the big question. It's a little unfair to compare taxes in the Norwegian countries and Canada versus our taxes, because in the Norwegian countries, they have minimum salary that is subsidized by the government. They also have government pensions that far exceed anything that we have in Social Security. So if you cut out if you were able to cut out what actually is the cost for the taxes for medical care, you can add a lot to taxes depending upon what you want. It's the same way in Canada. I represented 20,000 families in Canada. And if you asked, and I did on numerous occasions, what do you think about your healthcare system? They will tell you that the only thing that upsets them about their healthcare system is the government keeps trying to cut it. And they get very upset. But also in Canada, you can't use it either because they have a government pension and that everybody is required to participate in. And it's kind of interesting, we don't talk about it in this country, but we have something called railroad retirement that costs more in taxes for those people covered under the Railroad Labor Act. And they get far more than Social Security for that benefit. So, you know, you have to look at, it's a little bit unfair when someone says, you know, they pay 60% taxes, Canada pays 40% taxes. You have to say what above healthcare is included in those taxes.
Right.
And that's where I think people get confused.
I think that's very wise.
Certainly a tendency to do.
Wise.
I wanted to just comment on the concept of propaganda or knowing your facts, that, you know, how many people have a fact check server that they check regularly? And how many people know people that don't have a fact check server that they don't check regularly? Yeah, so educating people about, you know, instead of argumentative, say, hey, well, I checked factcheck.org or I checked the truth on that, and here's the actual data, is a really important part of calming people down. I mean, people are scared and they get scared and they don't realize that, oh, that might not be the truth. And so, you know, that's, you know, another area of making change is just checking the data and checking some accurate, unbiased sites.
And my point with this, by the way, is that comparison in one form. Other cultures have been able to accomplish this. I listened to Bill Moore went across this thing's like 10, 12 years old now, went across 5 countries, and he talked about Germany, Taiwan, Japan, Switzerland, and I'm blanking on the 5th one, about their socialized methods. These are social democracies. Listen to that phrase, a social democracy. And those social democracies are, so he interviewed the former Prime Minister of Switzerland, who said, when we brought this up in the 80s about having universal health care, it would almost cause riots in Switzerland. Think about that for incongruity. Right? And it was, they won by 2%. This was like 1999. He said, if we did it now, it would probably be 90-10. He so much believe in this. We're talking about a cultural belief system about vis-a-vis how are we going to govern around this thing called health and the resources we all have. That's the issue.
About time for probably just about one more question. Sir.
Somebody mentioned the high cost of prescription drugs.
Yeah.
And isn't it true that some people have to go to Canada to get life-saving drugs because they can't afford to buy the same drug in the United States? How is it that Merck or Lilly can sell a drug in Canada for a fraction of the price it costs here? Why do people have to go to Canada to get their drug? What can be done about it?
I think we could do a whole other panel on prescription medicine. But
I don't know the answer to the whole question, but I will tell you, I think the last thing I read said that I think the last 3 or 4 years, generic drug prices have increased by 200%. You know, things have definitely gotten out of hand. You know, I can't remember. I recently saw something talking about, you know, some of these venture capitalists. I mean, I forget the guy's name who got arrested recently, but even if there's just something I watched, a venture capitalist went and bought a drug for something called Wilson's disease. And, you know, it's the only drug out there on the market. And they had the family, you know, it costs $20 a month. Well, now it's $10,000 a month. And they actually showed the head of this company in Congress being grilled by Congress. You know, this isn't fair, this isn't right. And then, of course, that was 2 years ago and nothing's been done. Mm-hmm. So again, this is what government needs. You know, I'm not a huge person for a ton of government intervention, but there are cases like this where the public's being taken advantage of, where we can only rely on the government to help us.
Good.
You know, there's this term called robber barons. You ever heard of that? Cornelius Vanderbilt comes to mind. So in 1910, Teddy Roosevelt, because the mines were full of this, and people were dying in West Virginia because there was no safety involved, and basically Teddy Roosevelt went to him and said, this will change or you're taking me on. You decide. And that's what he decided was best for the common man, for the good of the country, was that needed to change. And he was willing to do that and stake his public reputation as well as political future on that. There are some things government is the only group that can handle it. Are we going to take on Bill Gates and succeed? Who in this room can do that? Who in this state can do this? There are some things, that's what government's about, you know?
It's an interesting conversation to support capitalism.
Yeah.
One step, one part of the economy, and to say, but we can't have capitalism in medicine because, you know, you put situations like that at hand. But on the flip side, is say, well, we can't have socialism because, so some kind of melding in the middle.
So we need to take a different angle from this,
Yeah.
from what we've been doing for 100 years.
Change the Affordable Care Act to get a better balance.
Changing the Affordable Care to get the perfect system.
You vote.
So I would like to
That's all
just
that you have to
address
final
the
comment.
prescription
Yeah.
drug price
Sure.
question for a second. Just to give you an example, so in England, the price of an EpiPen 2-pack recently, they priced it out $69. Here in the US, $600. So kids are having their EpiPens rationed because the parents can't afford to continue buying them. That's what happens when we don't allow for the negotiation of prescription drug prices. We know that where the VA is involved in negotiations over healthcare costs, they're able to hold them down. We need to allow the federal government to negotiate prescription drug prices, and the reason it's not happening is money in politics. It's very, very clear. So there is a corruption problem happening in Congress, and it's the corruption of allowing the pharmaceutical industry to dictate that Congress cannot actually do its job and provide for these negotiations to happen, to hold down costs for healthcare consumers. And how do we solve the corruption problem of the folks who've been bought and paid for in Congress? You solve it by voting them out in November.
Don't tell me you want to drain the swamp, do you? Oh my God, drain the swamp.
Thank all of our panelists this evening, and I'll have Rob come and make closing remarks.
If we just had 5 more minutes, we could have solved everything. I want to thank so much everyone for coming out. I want to thank the planning committee because a lot of work went into this. Wayne and Emily Vance, and Wayne was keeping time down here. Kathy Stoltz, Margaret McGovern, Norma Blake, Terry Buell, Kathy Smith, Andrew, Bob Andrew. They worked really hard. I want to thank our co-sponsors. If it was your child, the 9th District Disability Caucus, Brown County Common Ground, Brown Countians for Quality Health Care. I want to thank our panelists, Dr. David Dunkle, Dr. Mary Beth Hensley, Dr. Michael Kolenda, and I want to thank our moderator, Jill Sheridan, and I want to thank Liz Watson for coming. I wish Trey Hollingsworth had joined us. I am so glad that everyone else is here, and I especially want to thank my wife, Karen Greenstone, who is the organizer par excellence, who really made this thing happen.
Thank you for coming, everybody. I appreciate you being here.